I'm jumping into a important topic with regards to the brainstem and COVID and some of the unusual neurological presentations that people may have around the COVID infection. And I'm going to be highlighting this case report here about autoimmune rhomboencephalitis. Fascinating case, and they're useful in that they help us to be able to understand a little bit more about what may be going on. And so I'll be taking that case apart and trying to correlate it to what you may be experiencing or some of your family may have, and they have no idea why it's happening. So I'll be trying to give some insight into that. But before I start, just a reminder about the unseen threat, measles. Is it about to intensify amid COVID? You may think that this is not so much of an important topic for you, but I am telling you that based on what's happening in the US, I am predicting that this is likely to be a problem across the Western world. And I am looking at the correlation between the circulation of measles and the circulation of COVID, a really important topic. And therefore, what are some of the longer term outcomes if we have both viruses co infecting and co circulating through a population? So, please, if you are interested in analyzing the science, please join me. The link is below. It's on Thursday, the 20th of March. So let's get back to this case. And in order to understand what I'm talking about, you have to first know where I'm coming from. I'm coming from the principle of the COVID storm, where in a situation where you have immune priming, and in this case, I'm talking about COVID vaccination, immune priming, along with recurring COVID infection, it presents the scenario that I call a COVID storm. And what the storm means is spike triggered autoimmune response mechanism. Because based on my research and based on the evidence coming through, everything is related to this spike protein. And it seems in some people on re exposure to the virus and re exposure to spike protein, they have really unusual presentations. So I'm going to take a few points around this so that you understand what's going on, and I'll try and simplify it as much as I can so that it makes sense. So let's start with the case here. This is um, this is a case of autoimmune rhomboencephalitis. It was published in I think February of this year. The publishers or the writers were the USA from the University Medical College of Georgia, and it's a case report. So there's just talking about one person. He was 31 years old, and he developed post-infectious autoimmune rhomboencephalitis. And this is 2 weeks after COVID. So I'll take you through the case in a few steps. So this is it here. He's 31 years old, fit and well. And the only thing he had in his past medical history was a recent COVID infection. He uses tobacco and marijuana, formerly used alcohol, and he presented with right sided weakness, right facial droop, slurred speech, fever, and altered mental status or confusion. Now, this is more of an extreme presentation, but the importance of this case report is that in everything in medicine, you have a spectrum of presentation. And so some people may have quite severe symptoms. Others with exactly the same condition can present with much milder symptoms, but it is likely to be a very similar diagnosis. And so this is why I think that this case report is so important. And in this case here, it started 5 days prior. He had a severe headache, fever, and hiccups, which then progressed to weakness and speech, slurred speech. That's what dysarthria means. This is where it gets important. He tested positive for COVID 2 weeks before the onset of symptoms, which manifested as a mild flu-like illness. Okay? This is really, really important because this is how COVID is presenting now. Really mild infection. And so people are saying, well, it's no big deal. It's really mild. You don't get severe lung disease anymore. I'm just warning you that the COVID storm can affect, in theory, any organ. It's just happened at the beginning of the pandemic, it affected the lungs, and the lungs would kill you very quickly. That's why you noticed, that's why when people couldn't breathe, that's why the world panicked. But ask yourself the question, if the same number of people were dying from a heart storm or a kidney storm or a brain storm, is it just because it sounded worrying with the respiratory system why were responding? Or is it because people are still dying? So it's a very important point. Now, the other thing that I'm glad about with this case is that they highlighted his vaccination status. The patient reported being vaccinated for COVID-19. So, what I'm looking for here, and this is what I think is very important to try and understand, is in the vaccinated cohort who are having recurring COVID infections, how do they present? What are the immune responses that cause them to have symptoms? And this is very, very important, maybe an inconvenient question. And you may wonder, well, why am I highlighting the vaccinated cohort? Well, largely because it seems COVID is circulating more highly in the vaccinated regions. Some people will argue about that, but whichever way you take it, it's circulating in highly vaccinated regions. So, my suspicion is that unless the unvaccinated cohort who have natural immunity have something like interferon autoantibodies, they often don't get recurring infection at as significant a rate. But that's a separate issue. Let's just focus on the fact that, in theory, this can happen to anyone if they have a reinfection and they have been immune primed. So at the time, the person was investigated for a stroke. And what they found when he arrived, he had a temperature, 39 degrees. He was alert. He had some slurred speech. He had some facial weakness. And he had problems moving his left eye, we call it ophthalmoplegia. And he had numbness and weakness on the right-hand side. And then the MRI confirmed a brainstem lesion centered in his left pons with mild enhancement and moderate vasogenic edema. So this was the presentation. And at the time, they weren't thinking that this was COVID because they had never seen this kind of presentation before. And just so that you understand a little bit of the science around the brain and the brain stem, this is just showing you a picture of the brain. This is in someone's head. The brain here and the cerebral cortex. Down here is the cerebellum. And here is the brain stem. And the brain stem is connected directly to the spinal cord because it has all of the fibers going down to supply the rest of the body. Additionally, the brain stem is where your breathing center is, your vasomotor center for heart rate. It's where sleep is. There's also control there. If this is damaged, and actually, if you drink alcohol, it's oftentimes the brain stem that is affected with the dizziness, the vomiting, and so on. So this is an important part of the connection to the brain. This is the cut section, so where the brain is cut in half, right through the middle. This is the corpus callosum. This down here represents the brain stem going all the way down. This is the pons, the medulla, the cerebellum. So the primary area that was affected here was in about this region of the brain stem. And as I said, this is a very important part of the functioning of the body. If you have anything serious happen in this region, so if you had a stroke in this region, that can cause a locked-in syndrome where somebody can't respond at all. So it's a very, very important part of the body which has limited backup resources. And so anything that affects it is very, very critical. The other thing to know about the brain is that the brain is normally protected, very secure. This is what it looks like with blood vessels coming along. and you have this very sophisticated blood-brain barrier. So the blood will be in here, then you have very tight endothelial cells around it, then you have another pericyte, then around that you have an astrocyte. So this is like a very sophisticated protection to keep the brain separate from everything else. Anything that damages this is likely to cause an impact on the brain. And so that's an important point for us to try and understand. So, as we go back to the case, as we said, it was confirmed that he had brainstem impact. I don't know if you can understand this picture here, but this is showing you some sections, cross sections of the brainstem where there is some swelling in the pons. If you remember the cut section I showed you, this part here is where he has some swelling. So the diagnosis was made straight away that there is inflammation here. Their issue was that they didn't know what was the cause. So he then had a number of investigations, including a lumbar puncture where they take samples from the spinal fluid. And they thought maybe it was infection. They put him on antibiotics. He had been handling raw meat. So they thought that maybe that could be it, but he wasn't getting better. And so, therefore, because he wasn't getting better, they had to take a step out of the normal pattern. So, on the second day after admission, the patient continued to worsen acutely with worsening of the bulbar symptoms, that's brainstem symptoms with speech, swallow, more weakness. And therefore, they put him on intravenous methylprednisolone 1 gram daily. This is a big dose of steroids. And it's one of the points is that when we're talking about this kind of inflammatory process, you need high dose steroids. You don't need baby steroids. 6 milligrams of dexamethasone is not going to work. I'll have a whole presentation on steroids soon, but this is big dose steroids, and they had to give him one of the biggest doses we give, and so it's about easily 10 to 20 times bigger than the dexamethasone doses. So this is huge doses of steroids to try and suppress the inflammation. And critically with steroids, if you're going to use them, you need to use them early. And this is how serious it was in this patient, is that after the admission, he still needed to be intubated for impending respiratory failure. And they repeated the lumbar puncture. They didn't find anything else. They did a repeat MRI scan of the brain. They continued with the high dose methylprednisolone, and gradually the patient started to improve. But critically, they found no other cause for these symptoms. And so, therefore, at this point, the patient was ultimately diagnosed with post infectious rhomboencephalitis secondary to his recent SARS-CoV-2 infection because they couldn't find anything else. Really, really unusual case. So what this is more of a severe case. And I want you to therefore see kind of like, as I said, the cut section of the brain. This is where most of inflammation was in the pons. Oftentimes, you can get inflammation in the cerebellum as well, and sometimes in the thalamus. This is what happened in the case of Japanese encephalitis that they thought was secondary to the vaccine. So, for some reason, this part of the brain and the brain stem is vulnerable to autoimmune responses, most likely connected to the spike protein. And so, in that context, then, in order to understand what can happen, as I said, that brain stem is primarily where is affected when people get tipsy or drunk. So, meaning if you get fully drunk, you go comatose, you collapse on the ground, and that can be quite serious in itself. The early parts, it changes some of the behavior. You then start to lose balance, and the balance part of the body here is oftentimes in the cerebellum. So clearly, alcohol has a significant impact on this part of the brain and brain stem. And so the good analogy is that it's like being drunk all the time. And so that's the bit that a lot of people are struggling with. And they don't even see the connection with a recent infection. What I have observed is that people, you have to dig for them to say, yeah, 2 weeks ago, yes, I felt quite tired and fatigued. I had a bit of a headache. That was it. They forget about it. And then 2 weeks later, they start having unusual symptoms, which they don't connect to that prior episode. And that's the bit that I think is very important, not just for you to be aware of, but it's a very important clinical bit of information, because I think clinicians need to be aware of this so that they look out for those symptoms when what would be classed as an unusual ongoing dizziness, balance issues, non-specific, nobody can find anything, the scans are okay. What is it? And that's where I think that this is likely to be part of that spectrum of rhomboencephalitis, but very mild compared to what happened to that 31-year-old male. And the point is that in the context of what I am looking for with the COVID storm, and just in case you're just joining me here, the COVID storm is what I'm referring to, where you have recurring infection in a population that has been immune primed. You can get unusual autoimmune processes, and it can affect almost any part of the body. And we need to get on top of it. It doesn't mean everybody needs steroids, because it usually has to be pretty severe. But potentially, if we have a better understanding of it, and we have better imaging techniques, because our current imaging techniques, even with an MRI, a 1.5 Tesla MRI, is probably not going to pick up anything. And so we may need to have even more detailed imaging of the brainstem when people have this kind of presentation. It is very complicated, and it's not easy, because there are a lot of other things that can present in a similar way. However, at this point, I think that it is essential for us to have in our differential a recent exposure of COVID-19 to try and pick up if this can be part of the picture. Final reminder for you is that I want you to remember to join me for the unseen threat. Is measles about to intensify? And this is because I am seeing some patterns that I think could be related to ongoing circulation of SARS-CoV-2. A final point that I'd want to make as well is, if you're interested, coming up very soon, we're working on a pattern with regards to spike detox. If you are concerned about this, you need to make sure that you follow up on the links. Make sure you look at the course, follow up with what we're doing, because we are building something very important now to try and find ways to ensure that people are protected. There's a long way to go. And the truth is that we don't have enough scientific attention on these things. But we will use whatever we have to find the answers that we can. Have a great evening.